Yeah, 8:32. I'm sure a few more people will join, but we've got a good little group here so
Yeah.
far. So good morning, everyone. So welcome to the Geriatric Psychiatry Web Education Series. Few reminders just before we get started. One is to be mindful that this session is being recorded. Our Secretary Elle put some links there in the chat that you can see where to access the videos after. We ask that you stay muted throughout, and we'll hopefully have some time at the end to ask some questions. So feel free to put those in the chat. Elle also provided some forms for attendance and credit, so don't forget to fill those out. Otherwise, with that, I'm very happy to introduce one of our own, Dr. Megan McNeil, who's a geriatric psychiatrist on our team. She works primarily on our acute care inpatient unit, but continues to do some outreach work as well, and is the mastermind behind the web education series. So she'll be presenting today on psychosis in the elderly, which we look forward to.
Oh, thanks so much, Caitlin, for that introduction. I'll get started right away. There is a lot of material to cover, so I will be snappy, but it's nice to sometimes have a smaller group. It might mean that people are a little bit more likely to ask questions at the end and be a little less shy. It's an intimate group. So, uh-oh. Okay, now it's not advancing. Oh, yeah, it is. Okay, we're good. So we're going to talk about psychosis in the elderly. I have no disclosures to make today. I'm not being funded by a third party. I have no involvement in any kind of group like a speakers bureau for which you get paid. What we'll do today is we'll start off by starting with some basics, just in case some people are not as comfortable with psychiatric terms or just need a little review. We'll review also the epidemiology, or how frequently we see psychosis in the elderly, who it happens in, what the different disorders which present with psychosis. And in keeping with that, if you see someone with psychosis, we'll go through a differential diagnosis that you can think about in order to decide which underlying disorder is the most likely. And today we'll review the assessment through 3 different cases, and we'll talk about the diagnostic considerations. We'll also review the management and treatment of the underlying disorders based on diagnosis, certainly focusing on the psychiatric aspects. So when we think about psychosis or psychotic symptoms, we're not saying that these are specific disorders. We're saying these are symptoms. So they're psychiatric symptoms, or symptoms of a psychiatric nature, but similar to like chest pain. So if someone has chest pain, they don't necessarily have a specific problem. You come up with a list of problems that you think may cause chest pain, and there's lots of different causes. Psychosis is no different. When we look at what those specific symptoms are under that kind of broader idea of psychosis, we have delusions. So when a patient is talking about things that have happened, or things that are important to them that are clearly not based in reality and are false. And that belief is unshakable 100%, no matter what you say, no matter what evidence you present, they will continue to hold on to that belief. That is a delusion. And there are lots of different themes that come up in delusions, which are helpful, that can help be one piece of the puzzle to tell us what the possible underlying diagnosis is. But we need more information than just what the specific delusion is. Same with hallucinations. They are very helpful in pointing us in directions. What they are is an abnormal perception that happens to a person, but there's no real stimulus behind it. So, for example, if I'm looking out and I see something where there is nothing, that is a visual hallucination. Now, if there is something that I'm pointing to that isn't what I think it is, like if I'm pointing to a hat on a hat rack, but I think it's a cat, that's an illusion. So it's just a little difference in the definitions there. The third type of just to go back to the types of hallucinations. So you can have visual, auditory, you can have changes in your sense of smell, olfactory, in your sense of taste, and in the sensations on your skin or bodily sensations. So these hallucinations can happen in all of these different modalities. And where the modality is can again help us be part of the puzzle of understanding what is going on. So the third type of psychotic symptom is disorganization. So you usually discover this when talking to somebody and if you have profound difficulty in understanding what they're trying to say. They may start off with on one train of thought, move to another. This can have various degrees of severity. So people who are quite disorganized may not have full sentence structure. At its worst, they could have something called word salad, where they're just saying random words and there's no clear links between these ideas. I talked a little bit about there's different themes of delusion. So we won't go through all of these, but some of the more common themes are that of persecution. So someone's out to harm me. They might be watching me. They may be monitoring me. They're messing with me and harassing me. There's delusions of control, that I think something outside of me is changing my body. This could also impact thinking. Sometimes people will think that others, their loved ones, their partners are cheating on them. Guilt. Sometimes people have, extreme, profound, pervasive ideas that they've done something wrong that is completely out of keeping with reality. So that's a good point. So these things are out of keeping with reality, but also out of keeping with cultural beliefs. So sometimes that can be tricky if you're not as comfortable with the culture, but being curious and trying to figure out if this is culturally sanctioned or not is an important part of the evaluation. And so they can also affect the bodies, and they can also, in somatic delusions, and they can also affect our understanding of what the meaning of the events are around us. So in delusions of reference, neutral events are interpreted to have some personal meaning, important meaning, usually a negative connotation. So that's the background of terms that'll hopefully help throughout the talk. We're going to start right off with a case. So an 87-year-old woman was seen by Geriatric Psychiatry service. She had been admitted to hospital. She had been widowed 2 months prior. The symptoms that she had on presentation were increased confusion and functional decline. The confusion was pretty quick onset. She was diagnosed with a delirium. She was found on laboratory investigations and physical findings to have a urinary tract infection and a pneumonia. So during her hospital stay, the delirium waned. But what came through was she had odd beliefs. So she was complaining to nurses. So this is what was on the referral to psychiatry. Believed that fecal matter was rotting in her bowels. She was reporting not having bowel movements, but nursing were aware that she was having bowel movements. But this seemed to be a belief that was unshakable. And due to this concern, she was limiting food and fluid because of fears that things are going to kind of back up. In the interview, she endorsed these things again. In addition, she had reported that she felt that she had failed her family. This came up over and over again, that she felt unworthy and that she felt that she had done something wrong to her family. She also complained a lot of having like a globus sensation, so like an egg in her throat. And she expressed profound fear of eating and drinking, felt like she could not do that. So in further exploration of other psychiatric symptoms, she did endorse a lot of mood symptoms. So she did describe her mood as being depressed. She had a very poor appetite outside of her beliefs around what eating would do to her body. She had poor sleep, very low interest, very low or joy, no suicidal ideation, no hallucinatory experiences. no in the auditory or visual areas, no thought insertion, no withdrawal, no broadcasting, these no delusions of control. And she also denied any significant substance use history. In looking at further history, she had a past psychiatric history, possibly of depression after having miscarriages early in life. She had an appendectomy, she had gallstones, nothing particularly contributory. Her current medications list was very sparse. Lorazepam 0.5 PRN and haloperidol 0.5 PRN, and no longer taking this, had been taking this when she had the initial symptoms of delirium. Looking at her background, she was married for over 60 years. So this loss of her husband was pretty profound. She's now living on her own since the death of her husband, a really big change. And she had 3 children and 1 lived locally. The son had reported, so they were interviewed together for part of it, of the initial interview, but he reported no changes in memory, no history of falls, like no head trauma or anything like that. But he said there was a decline in function, and likely over the past weeks, she just didn't seem able to care for herself. She wasn't dressing, she wasn't eating well. So that had a longer history. On mental status exam, she appeared her stated age. She was thin. She described her mood as depressed, and her affect reflected this. She seemed quite dysphoric, with poor eye contact. She was very vague. So when asked questions, she would kind of do the head turn to her son, often say that she did not know the answer. When pushed a bit, though, she sometimes would come up with the correct answer, but would reflexively answer, I don't know. She often returned to the guilty themes. And then when kind of categorizing her delusions, this concern around her stomach not functioning would be a somatic delusion. And then there's another term, nihilistic delusion. So when people feel that things are rotting or their organs are lost or that things don't exist, I mean, the term is nihilistic. It's not a very common delusion, but it can happen. And we'll talk a bit about it later. And then maybe surprisingly, her MMSE was actually not too shabby. 26 out of 30, and she had lost 3 points for orientation to time. So, so what do you guys think? Like, what do you think might be the best diagnosis in this case? I don't think we need to like put it in the chat or anything. If you can just mumble it to yourself or write it down. Commit though, then we'll move on. Okay. So the diagnosis was major depressive disorder with psychotic features. Some of the things that helped kind of come to this diagnosis is, well, number one, the prominent mood symptoms. So her music criteria for major depressive disorder certainly is part of it, a big part of it. But some of the other features, like the timeline being of weeks, being in the context of a recent loss, the types of delusions that she had. So guilt and somatic delusions are very common in geriatric psychiatry. Particularly somatic delusions around the bowels not functioning, things backing up. At times, there could be a dose of reality. At times, people do have slowing down of their bowels, but it's the focus on it and the concern about it that is extreme and out of keeping with reality. And then when we look at some of the cognitive symptoms, common presentation of major depressive disorder is an older person saying they don't know, seeming like they can't produce information. But when pushed, can actually, so it does seem like more of an effort problem. And then she did well on cognitive testing, something that is incongruous with how she seemed in the interview. A complicating factor for sure in this presentation was the delirium. But this is not uncommon, and often real life cases are quite messy, and there can be multiple things going on, particularly when people are in hospital. So it certainly made the diagnosis quite tricky, though. All right, so we're going to move on just to kind of flesh out some details around psychosis between cases. So psychosis is a really common issue in geriatrics. If you look at younger people versus older people, you're more likely to have psychotic symptoms in an elderly population than a younger. For example, up to 23% of older adults will experience psychotic symptoms at some time. And then if we look cross-sectionally at different populations, like in inpatients, we think it's 5 to 15% have psychotic symptoms. And that's a general inpatient. That's not a geriatric psychiatry or psychiatry inpatient group. And then if we look at nursing homes, this is a huge difference between the lowest and the highest reported percentage. But it's very common for people in nursing home to have psychotic symptoms. And in working in geriatric psychiatry, it's a really common reason for to our service. So kind of the same deal. I want you guys just to think about this for yourself, write it down, commit to the answer. But what do you think the most common cause of psychosis is in the elderly? Is it schizophrenia? Is it dementia, depression, or delirium? I'll give you a couple of seconds. And then the correct answer is dementia. So we'll look at the common etiology. So if you look at the pie graph, this is all etiologies of late life psychosis. So the big pieces of the pie really are dementia and depression. So dementia being the largest, depression being the second. And then we go around to less common delirium, and delirium is a less common phenomenon. Certainly if you work in the inpatient wards, it is common, but when we think about the community at large. Whereas depression and dementia are very common diagnoses. You can have another medical cause outside of delirium, be an etiology, also drug intoxication or withdrawal. And then if you look at the very smallest two parts of the pie, those are the psychotic disorders. So psychosis, much more common in other problems other than what we call primary psychotic disorders. So schizophrenia or a delusional disorder. And so delusional disorder, we're not going to talk a ton about, but that is a psychotic disorder where someone has, the most prominent thing is their false fixed belief. And they may have some hallucinations, and they don't have a lot of other psychotics, so not a lot of disorganization. Yeah. So delving a little bit deeper into the differential, I know this is a little bit busy, so we're just going to go from left to right here. So some other medical causes that you want to think about in seeing someone who you have a high suspicion. So endocrinological problems like thyroid issues, some vitamin deficiencies like B12 and folate, neurological disorders like MS, Parkinson's, and seizure disorders can be accompanied by psychotic symptoms, as well as autoimmune disorders or perineoplastic syndromes. Delirium, certainly we know that that could be its own talk, but there are psychotic symptoms that are seen in delirium, often visual hallucinations, but there can be delusions as well. But the main features of delirium really is this abrupt onset, fluctuating course of level of consciousness, in addition to these other features. Usually caused by underlying medical condition, though it's sometimes very hard to discern. There might be also disorganization as a feature of delirium as well, but these timeline and that core feature of attention should help. There are also some psychotic symptoms that arise within sensory impairment. So, for people who have say, severe visual impairment, they can develop visual hallucinations that can be pretty elaborate, cartoon-like hallucinations. That's called Charles Bonnet syndrome. People usually retain insight, so they're not acting on these hallucinations. They recognize that this is a strange phenomenon that's produced by their brain. And similarly, with hearing loss, people can develop musical hallucinations that are usually kind of old songs that are repetitive, songs usually from someone's childhood that get worse in environments with low sound. Um, Moving on to psychiatric causes, we talked about mood disorders. We didn't talk about bipolar disorder, but certainly that can be a cause. And then the psychotic disorders. The different types of dementia that can cause psychotic symptoms are more than that are listed here, but Alzheimer's, vascular Lewy body dementia, Parkinson's, and Huntington's can be associated with visual hallucinations. We'll talk more about that later. And then substances, either in intoxication, like with stimulant medication, or withdrawal from something like alcohol. So getting a full history is very important. And because getting the diagnosis is important. So when we talk about all these different possible causes, they all have different treatment strategies. And just to drive this home with an example, if someone has a Lewy body dementia, there are specific things that you would use to treat the psychosis associated with that being cholinesterase inhibitors. So if you miss the diagnosis of Lewy body dementia, you may miss very effective treatment. But you could be causing harm as well if you go for a dopamine blocking agent. Because these people have neuroleptic sensitivity, they have a significant Parkinsonism in relation to using these medications, and it can be dangerous. Whereas if it's a depression, if you miss the diagnosis, then you're going to miss out possible treatments with antidepressants or ECT. And certainly with any of the underlying medical issues, you want to address the underlying medical issue. So when we look at psychotic depression, major depressive disorder with psychotic features, we know that psychosis is more common in elderly patients. People are less likely to report guilty feelings than in the young, but I would say it's still common. Cognitive impairment is more important. And some of the common delusions are somatic delusions, persecutory delusions, and delusions of poverty. We did talk about nihilistic delusions. So a term that's can be used is Cotard syndrome. So this is when people believe they are dead or their organs have been lost or decaying. And it can get more profound that I don't exist, I'm dead, you don't exist, the world doesn't exist. So this is could be a possibly troublesome belief. People can neglect themselves or be overconfident. That's rare. It is seen in patients with depression or bipolar disorder, but is also seen in patients with traumatic brain injury, migraine, epilepsy, or people have strategic strokes. And there may be some correlation between having some right hemisphere dysfunction with developing this syndrome. So moving on, what is the most effective treatment for depression with psychosis in the elderly? So is it SSRIs, MAOIs, ECT, or antipsychotics? So let's commit. And gold star if you guessed ECT. So it's probably not the most common treatment, but it is the most effective treatment. ECT is the most effective treatment for depression in general, and is likely more effective in depression in the elderly compared to younger patient populations. So there are CCSMH guidelines for major depressive disorder that came out in 2024. And they have suggested different times when, given some advice about when to suggest ECT or when would be good times to consider it. Particularly if there's a history of a good response to ECT, if there's failed treatments. But they also list the psychotic features as a good reason to consider it as a first-line treatment. Some other reasons would be suicidal ideation, significant concerns around safety, including severe physical illness. But the mainstay of treatment with major depressive disorder with psychotic features is the combination of an antidepressant and an antipsychotic. Sertraline and olanzapine is a great example of a good combination. So for our first case, the patient was admitted to psychiatry, was successfully treated with ECT, and went home. Our second case is a 76-year-old married woman, initially seen by geriatric psychiatry, also admitted to hospital, but was referred to geriatric psychiatry for additional evaluation. This person had a lot of psychotic symptoms, predominantly, or actually most significant were for visual hallucinations. There were very elaborate content of her visual hallucinations, and some of this content was very sexual and very disturbing. So she had felt she had witnessed her husband engage in sexual activity. She also described her daughter doing the similar behaviors within the house. She was very upset with him because of what she had perceived and threatened to call the police, but she hadn't yet done so. The family actually reported that she had fluctuations. So she did seem like at times she would communicate clearly, and at times she was vague. It seemed like she was not there. The family had to work very hard to communicate with her. She was admitted to hospital under general medicine. So when she's seen by geriatric psychiatry, she does endorse this, that she's just seen dozens of women living in her house. Some of them are naked. She perceives them to be prostitutes. And she reports that they've actually been present for months. Like this has been an ongoing problem that has worsened. And this is a direct quote. She found women in jars and bottles in the fridge, in the buffet when she opened it, in the barbecue, in the dresser drawers, and in the closet. So really profound quantity of hallucinations. And then in the interview, she was seeing women in the hospital room could describe them. Some of them were very big, some of them were very small. She could describe them in great detail. She had some other psychotic symptoms, persecutory ideas, feeling like her husband's watching her, trying to poison her, and had delusions of control, that he was controlling her bodily functions. Looking at other details of her history, she had no psychiatric history. She had no history of sleep disorder. That will come up later. She had no she had hypothyroidism and chronic back pain, a maternal history of bipolar disorder. Her current medications were citalopram. That was started in hopes of treating the visual hallucinations and illusions. Clonazepam was also prescribed. She'd been on Synthroid previously, and she was getting as-needed haloperidol. That was because initially the feeling was she probably did have a delirium. For cognitive testing, so looking at delirium, you can understand why there was a concern around delirium, because her performance on concentration was rather poor. But interestingly, she also had difficulties with visuospatial tasks. Her memory wasn't pristine. 2 out of 3 on recall. On the MoCA, she scored 15 out of 30, scored poorly on attention. Poor visuospatial performance again, and that is much more robustly tested on the Montreal Cognitive Assessment. 3 out of 5 for recall, so not abysmal. Improvement with cueing, but again, attention quite. On physical examination, she had a shuffling, slow gait, decreased arm swing and a stooped posture. No tremors were visible. She did have cogwheel rigidity in the upper extremities, and this was asymmetrical, so worse on the right than the left. Vitals were stable, but her temperature was a little bit up, which was a bit concerning because she'd been given haloperidol and had these features, but that turned out not to be an issue. She had no real abnormal laboratory investigations, and her CT was not contributory. So, playing the game again, what do you think the likely diagnosis is? So I gave hints that, delirium was on the table, but thought probably not. So her diagnosis was Lewy body dementia. And so some of the features would be like the sensitivity that she had to the haloperidol, possibly underlying Parkinsonism, but the nature of her visual hallucinations and the time course, as well as her cognitive impairment that showed inattention and visuospatial deficits really point to a Lewy body diagnosis. And then she also had the great history of this fluctuating level of consciousness that on one hand does make you think about delirium, and you could get tripped up there, but is a core feature of the Lewy body dementia, and it can be hard to figure out. So this is, Lewy body is a little bit, there's been a lot of back and forth about how common it is. There actually was a different change in the diagnostic criteria in 2018 in hopes that this would probably become more accurate, because it's not as commonly diagnosed in the clinical scenarios as it is seen on autopsies. So we're trying to kind of narrow that gap, but it's unclear what the reasons of this gap is. So just so that you look at the core features where the arrows are pointing, this is actually one of the older articles. So this is out of date, like how often we think people present with these features. But the fluctuating concentration, the visual hallucinations, Parkinsonism, and REM behavior sleep disorder are the core symptoms. That one of the ways that you can meet the criteria for Lewy body dementia is to have two of these signs or features. So what does Lewy body dementia psychosis look like? It is a little bit different. So it usually is recurrent. So it's not, maybe I had a hallucination one day or something. Usually, eventually, if it's there, recurrent complex visual hallucinations. And it's usually very well formed. People can describe these things in great detail, tell you what people were wearing, what they did, what their path across the room was. If they are often people or animals, children, sometimes really tiny people. That's called Lilliputian hallucinations. More mild psychotic kind of spectrum symptoms. Sometimes people will have these passage hallucinations where kind of out of the periphery, they feel like I saw something move. Also, sometimes people will have this sense of presence. They'll feel like there is something in the room. There's someone there, someone in their house, but they don't explicitly see anything. And then these visual illusions, like thinking that the hat is a cat. And then if you look at all these psychotic symptoms, we think now that this is present in up to 80% of patients with dementia with Lewy body. And it is very helpful in making the diagnosis. And I think I have two different dates. So the McKeith article, the one I'm talking about so that looks like it's actually 2017 or 2018. Treatment. So how do we treat these things? Just as our principles for treating psychiatric symptoms in dementia, we always, if we can get away with non-pharm, we usually try to do that. However, most people who are going to diagnose dementia with Lewy body, you're going to try acetylcholinesterase inhibitor in them anyway. And these are the memory medications that we use in Alzheimer's dementia. They are currently the mainstay of treatment. They treat both cognitive and psychotic symptoms, and rivastigmine and donepezil have the best evidence. If things are persistent, then we can think about using specific antipsychotics, but clozapine really is the only drug that has a good evidence base. It has issues with monitoring as well as side effects. Quetiapine is commonly used. And in the US, they have a drug specifically approved for Parkinson's, not approved for Lewy body dementia, but there is some evidence in Lewy body dementia. And some people, there's mixed reports around using memantine. So I'm mindful of the time. So we talked a lot about the dementia with Lewy body. Parkinson's is similar. The big difference between Parkinson's and Lewy body dementia is usually it's going to happen much later in the disease. And so you don't expect to see it early. If you see it early, you really actually are thinking about Lewy body dementia. In Alzheimer's, a large percentage of people have delusions or hallucinations, delusions being more common, most common being delusions related to memory failure, people stealing things, people putting things in one's home that don't belong to them. And visual hallucinations can also happen. They're usually more simple than in the Lewy body dementia. FTD, it's less clear about how common psychosis is, but delusions of visual hallucinations have been described. We know that there's a subset population of with a genetic form of FTD where the gene is the C9orf72, and it's an expansion gene where it can cause ALS or FTD. And then some of the Parkinson's plus syndromes, we don't think that psychosis is very common at all. The big thing to recognize for Alzheimer's disease is that as the disease progresses, and usually starting in the moderate stage, that the likelihood of psychotic symptoms increases as the disease progresses. Pretty rare to see it early in the disease. But if you do see psychosis in dementia, it is linked to poor quality of life, greater extrapyramidal symptoms, worse physical health, increased mortality, earlier institutionalized, accelerated cognitive deterioration, and increased caregiver burden. So these patients often require more care, and you're going to be ready for progressive illness. If it is non-Lewy body dementia related psychosis, but in dementia, you're going to use the same principles: non-pharm first, then evaluate for distress in the patient, family, and treatment team in that order. The new guidelines, CCSMH from 2024, suggests citalopram up to 30 milligrams, but you might want to monitor QTC if that's true. If there's moderate severity of psychosis, and then risperidone or aripiprazole. If severe, there is a black box warning for all atypical antipsychotics in dementia. So there are real risks, but they also recognize that these three drugs may not be adequate for controlling symptoms, and so other treatments may be required. So in this case, Haldol was discontinued, movement symptoms improved, but did not improve. Go to baseline. She was starting rivastigmine. She needed some extra quetiapine to manage her symptoms. And then we're going to burn through this case because time is of the essence. So this was a case that was referred to the geriatric team through the ER. He had a new onset of auditory hallucinations, and it lasted apparently weeks. Medically cleared, though, patient not distressed, family very concerned. He was an 86-year-old divorced male, 2 adult children living away. He was a retired teacher, lived alone. He was concerned about men working in the lot behind his house and that they were making so much noise that his bed was shaking. He also heard them singing old-time religion. He had, in actually talking with him, 1 year history of singing, banging, and experiencing tinnitus. He was seeing people behind his house. He felt that people were controlling his phone, controlling the heat, and persecuting him. He was acting on these thoughts, going out into the night with a flashlight, trying to find the people, called 911, wouldn't sleep at night. There were safety concerns. He had a gun in his house, but he kept the ammunition separate, but he had a machete by the door and said if he was broken into, he would defend himself. There's no mood symptoms, minimal memory issues. He was independent for ADLs and IADLs. He'd been started on a small dose of risperidone in the community, and so sleep had improved somewhat. No past psychiatric history. He had a bilateral hearing impairment that was quite severe, renal insufficiency, anemia, chronic disease, dyslipidemia, GERD. He was on 0.5 of risperidone, and had no family psychiatric history either. For social history, he had a small drink of scotch every day. He was a thin man. He was appropriately dressed, but he was wearing sunglasses because he perceived the light bothered him. His thought form, he was not disorganized. That was normal. His speech was normal. What was clear of these persecutory beliefs, his affect seemed euthymic. It was normal range, reactive, very appropriate. He did seem distracted, however, which was felt to possibly be related to auditory hallucinations. He scored at 29 out of 30 in the MMSE and 26 out of 30 on the Montreal Cognitive Assessment. He had no extrapyramidal symptoms and an okay. So just going through quickly the differential. So, we didn't think dementia, delirium, mood disorders, delusional disorder were important. He did have delusions, but the hallucinations were pretty prominent. He did have sensory impairment, however, like significant sensory impairment and some features of the musical hallucinations. So considered that, but it's a hard time to explain all of his behaviors and all of his beliefs with the sensory impairment. He may be underplaying a substance use, so we considered that, or schizophrenia. So the parentheses here is EOLOVLO. So early onset schizophrenia, late on schizophrenia, or very late onset schizophrenia. Sometimes people add the schizophrenia like psychosis. Labs were fairly good, but he had anemia, not surprisingly, and his creatinine was elevated. Imaging did not help. What's the diagnosis? So he was diagnosed with very late onset schizophrenia, like psychosis, or very late onset schizophrenia. And then I will just switch willy-nilly between late onset and very late onset. I apologize. So when you look at the diagnostic criteria for schizophrenia, DSM has no age limiting criteria. The diagnostic criteria are the same. If you meet it, you meet it. DSM-3 did have age criteria as a cutoff. But there are consensus guidelines that were created, and that just delineate these different times, and develop these different labels for the presentations in hopes of further study and understanding these illnesses better. It's not that common if you looked at the community prevalence after 65. So if you looked before 65, it might be higher, but 0.1 to 0.5%. There's a predominance of female to male, rather, more frequent. Some of the characteristics are auditory for hallucinations. Auditory hallucinations are common. When you compare to early onset schizophrenia or late onset, there is a high incidence of visual hallucinations in this very late group. The delusions, the most common delusions are persecutory delusions and partition delusions, which is a belief that there's a permeability to things that are solid. So people coming in through walls, ceilings, somehow getting through a window, coming into their house. There is less if you compare it, there's less disorganized thought form compared to younger presentations of schizophrenia. And then the negative symptoms like the anhedonia, the decreased affect, those things are much more rare in the very late onset folks. There are some cognitive differences as well. So this helps with this differential, like, is it dementia? Is it very with psychotic symptoms versus is it psychosis with some mild cognitive symptoms? So when we look at cognition in this group, impairment exceeds what we'd expect in general aging. So it, compared to the normal aging counterparts, their cognition is worse. The areas affected are not as consistent, but executive functioning, attention, sometimes memory and learning are common, also language impairments. But their cognitive performance is more comparable to early onset schizophrenia than it is to dementia. But again, these domains where there's problems are less consistent than in early onset schizophrenia. And it's much less severe than in major neurocognitive disorder. So if you compare to Alzheimer's dementia in the group with very late onset schizophrenia like psychosis, their learning is better. Language impairments are about the same, though you would not expect the deterioration that you would see in Alzheimer's. And when you compare executive functioning to that found in frontotemporal dementia, it's more of a working memory problem than the verbal fluency, abstraction, and impaired flexibility we see in FTD. So there's some hints out there of what could be causing this, because when you think about it, like, we think of schizophrenia as a neurodevelopmental disorder. So why at 86 would someone develop a syndrome that looks like what people present with at a much younger age? So some of the risk factors are being female. Some are having a risk factor is having a pre-morbid schizoid and paranoid personality traits. So there might be some propensity of psychosis. Conductive hearing loss is also associated, as well as social isolation. There's also changes in imaging. Some of them are similar to early onset schizophrenia, such as enlarged ventricles and decreased volume in the left temporal lobe. However, they're much more likely to have cerebral vascular findings. They are more likely to have infarcts and hyperintensities on MRI. Functional imaging does show hypoperfusion in the frontal and temporal areas. And so if you took everybody who had very late onset schizophrenia like psychosis, it would be very hard to say what is going to happen to that single individual. This is a little bit on the controversial side. There are camps that believe that this is basically just a prodrome to dementia. But if you look at the literature, there are people who tend not to decline and at 10 years do not have a diagnosis of dementia. So it probably is a mixed bag and hard to differentiate what will happen in the future. So for treatment, certainly with all psychotic presentations, you want to consider safety, you want to consider whether the person can function, or you can anticipate something really bad happening. Usually you do treat with atypical antipsychotics, you address sensory impairment, address social isolation if possible. The doses of antipsychotics are often much smaller than what you would need in early onset, possibly as low as 1/10 of the dose. So our case, our sir was discharged home, guns were removed from the house. He was followed as an outpatient by geriatric psychiatry. He initially had significant improvement, but unfortunately decompensated a year later. Their auditory hallucinations returned. He had more guilt, persecutory, and delusions of control, and had a lot of referential thinking. That was a very long hospital stay, but was eventually treated with olanzapine, which was effective, but unfortunately sedating. We tried some of the other aspects of managing his hearing, engaging him in recreation. He had an OT assessment to reassess his function. It was felt he did not develop dementia, and he was followed by outreach with geriatric psychiatry. So managed to leave some time for questions, and
Good.
I'm happy to take any questions that are out there.
Well, thank you so much, Dr. McNeil. That was excellent. See if anything pops up in our chat.
Clear as mud.
No, I guess yeah, clear as mud is right. Must mean you did just an excellent job of encompassing everything.
I'd like to ask a question, if I could.
Hi, Jeannie.
Hi, how are you, Megan?
Good.
Well done. Very, very interesting. Megan, I'm showing my age, but there years ago we called, we'd have these seniors who would come in and they
Yep.
would have people coming through the walls of their house and, particularly senior.
Yeah.
And they used to call it paraphrenia. Now that's
Mm,
disappeared from the DSM. Do you have any idea? We still get these people. I've got three today. Uh,
oh,
so, there's this is still popping up, but they have these vivid hallucinations. They
mhm.
probably have mild cognitive impairment, typically. And where do you see that as fitting in?
I think this is just a rebranding for that. I think they took it out of the DSM. I think, um, we still have to encapsulate who these people are. And so I think that that's what the purpose of the consensus was, is to say, okay, we're going to think of this as not a third thing, but we're going to say it's schizophrenia. Like DSM is not, I don't think, adequately addressing this population. So I think I would say like the very late onset schizophrenia, like psychosis, is probably the most appropriate term. And then whether they go on to develop dementia or not. There's that other Dr. Ismail from Calgary. He has the mild behavioral impairment kind of way of understanding these late presentations of psychosis. So that's another kind of way you can visualize this, that this is, like an odd presentation. It is a risk. Like we know these people are more likely 3.1 per or times likely than people who don't have these symptoms to go on to develop dementia. So that's how he's kind of
Right.
conceptualized it.
Good, thank you. Interesting.
Okay. We have a question in the chat. So regarding pharmacotherapy and dosing, what are your recommendations?
I mean, I'd say, if you're, and I assume this is for, I don't know which, doesn't matter, because I think my advice is going to be the same. So if you can try non-pharm, you try non-pharm. If it's distressing, you're going to want to start with low doses and go slow, monitor for side effects. I think it's tricky when you're starting an agent and you're like, at what point, if it's, I'm not going to stop if it's 1/10 of what, a general adult would get. I'm not going to be like, oh, it's a trial. I'm going to keep going if they're continuing to tolerate the medication, but I still go.